It's fair to say. And for those of you who made time in your lives to come, I want to say thank you so much. By the way, I'm Catherine Reed. I'm Director of Education and Content for AHCJ. Before I forget to do this, I want to welcome our sponsors. That would be the Commonwealth Fund, the Robert Wood Johnson Foundation, and our local host, the Georgia Health Initiative. Want to thank, in particular, the latter for the great ideas and the great conversation that helped shape this event, helped us decide what we really needed to be talking about. So we have held this event for many years, AHCJ, and every year I get this lovely email from my background source at the Rural Information Hub, and she says, "Oh, I'm so glad you guys do this." Every year she seems surprised that we continue to focus on the important issues of rural health, and there's real gratitude there on both sides for continuing to illuminate these issues, which feel urgent in any year, but especially right now because of what's happening on the federal level. So a few housekeeping items. We are streaming and we are recording. So please use the microphones for everything. Even though we're a small group, and ordinarily in a group this small and in a room this size, you could just call out a question from wherever you are. That won't help our virtual audience this time. So please, if you suddenly, spontaneously feel an urge to get up and ask a question, I think you should, but please use one of the microphones. There's one here and one over there. Also, low talkers, we cannot tolerate you today. So please try to speak up, and when you come to the microphone, don't be shy. I'm not picking on low talkers, I swear. We are missing a microphone. There's a stand there, but there's no microphone. Okay, well, I think what we should do, since we are a small group, I was going to ask Kevin, could you grab that microphone? And let's, real quick, since this is an incredible networking opportunity, starting with Huria over there, who will never forgive me for the rest of her life for doing this to her, would you quickly just go around and let people make sure the mic is on? Slide the button. There, oh God, yes, it's on. And just your name and your affiliation, real quick, that would be awesome, so people know who's in the room.
Hi, good morning. My name is Hire. My affiliation is New Mexico In Depth, and I'm doing a fellowship with AHCJ.
Good morning, everybody. My name is Bill Frescos. I'm with Shaw Media out of Illinois.
Thanks. Hi, my name is Karen Landman. I'm a freelancer based here in Atlanta.
Hello, my name is Sophie, and I'm a reporter with Georgia Public Broadcasting, so Atlanta-based.
Hi, I'm Angela Chow with Healthline, Medical News Today, Healthgrades, so basically Healthline Media ecosystem.
Hi, I'm Ellen Eldridge. I'm also with Georgia Public Broadcasting.
Hi, I'm Cheryl Weinstock, and I'm a freelancer.
Ana Gascon, and I'm also a freelancer based here in Atlanta.
Hi, I'm Rainer Rice, and I'm with KFF Health News based here in Atlanta. I'm also a member of the AHCJ board.
Hi, I'm Michelle. I'm a reporter at the Atlanta Journal-Constitution here in Atlanta.
Hi, I'm Hannah Ferfaro, and I'm a reporter at the Seattle Times.
Hi, I'm Jess. I'm with WABE, the other public radio station in Atlanta.
Hi, I'm Maya Homan. I'm a reporter with the Georgia Recorder based here in Atlanta.
Hi, I'm Trisha. I'm a freelancer based in Roswell, Georgia.
Hi, I'm Anika, and I'm a freelancer based in DC. My name is Golda. I'm a freelancer and also the host of a women's health podcast, and I'm based in New York.
Hey, good morning. Sorry. My name is Eli Newman. I'm with Bridge, Michigan.
Good morning. I'm Joanne Kang, and I'm with Georgia Health Initiative.
Hey, I'm Ariel Hart. I'm with the Atlanta Journal-Constitution.
Hi, I'm Nora Farrell with the Kate B. Reynolds Charitable Trust. We're a foundation that funds health improvement work in North Carolina, and we do some news funding in North Carolina.
Good morning, Eric Lind with the University of Minnesota. I'll be speaking on later on today.
Hi, my name is Jessica Schwinn. I'm a professor at Georgia Southern University. I'm speaking at 3 o'clock, but I was really interested in all the other talks, so I'm here.
Good.
Hi, I'm Sarah Brewer, and I'm with the University of Colorado School of Medicine, also speaking later.
Good morning. I'm Margaret Coker. I am the founder and editor of The Current. I've driven up from Savannah to be here.
I'm Andrew Jones. I'm an investigative reporter with Asheville Watchdog in Western North Carolina.
Good morning. Kevin Bennett, University of South Carolina, Center for Rural and Primary Healthcare.
Rachel Nania with AARP.
I'm Julie Chang. I'm the health editor at the Texas Tribune in Austin.
I'm Casey Balio. I'm with East Tennessee State University.
And you are, sir?
Oh, yes. I'm Kevin Ritter. I'm with AHCJ based in Chattanooga.
All right. Okay, so Casey, I think we can get started. Meantime, let me tell everyone what the Wi-Fi password is in case you have not discovered it from someone at your table. It's Discover2025 using the conference network. All right. So, come on up. Here you go. I didn't start it for you, but okay.
All right. Well, thank you so much for having me, and thank you to everybody for being here today. Again, I'm Casey Balio. I'm from East Tennessee State University, and I'm with our Center for Rural Health and Research. So today I'm going to talk a little bit about all things data, sort of what we know about our rural communities based on data, how we find data, some of the changes in the landscape around accessing data, and then a few tips for using and reporting on data or research. All right, so at all these meetings where we are with rural audiences, we always talk about what is rural actually, and I think we all sort of have this idea of what rural means in our head. Most people in this room probably have a really good, rich understanding of what rural is and how we define rural and how we talk about rural, but there are many different ways that we can see and talk about and hear about rural populations, and many of the people that we are writing for or talking with don't always know what that means or how we operationalize that. So on the screen are a few examples of what we often think of when we think of rural sort of casually. We have the mantras of older, poorer, and sicker. We have the food, fuel, fiber, and fun, which is always very challenging to say. And then on the right-hand side of the screen, this is something that came out of McKinsey just a couple weeks ago, where they tried to categorize different rural communities into this set of sort of criteria and into these different definitions of rural communities. These are just a selection of sort of how we casually think about rural and what rural means. But there are many ways that we can actually define rural and operationalize it. On the left-hand side of the screen are several of the definitions that various offices within the federal government use. Not even all federal agencies use the same measures or operationalize them in the same way. And that has some implications for how people are funded, who is eligible for funding, those types of things. And on the right-hand side of the screen is the Rural Health Info tool on Am I Rural, where you can type in any address in the country and figure out sort of where you are on the rural-urban continuum through all of the different measures. So all of that to say there are a lot of different ways we can measure rurality. Today we're going to talk a lot about what we know about rural populations from data. I do want to say that there are different ways that rural is operationalized in many of the studies and the data that I'm going to share today, but it tells a similar story in most cases, no matter which definition you use, but there are some differences on the margins. So when we think about rural communities, there are a lot of questions that we can ask, and today these are some of the questions that came to mind when putting this together. So first is what does the data tell us about our rural communities? How are they changing? How do they compare to non-rural communities? What rural data limitations and resources exist? And how is the data context changing? So here's our agenda for the next hour or so. We will talk about the current state of rural. So this first section is all about what we know about rural populations, rural health, and rural communities in those different buckets there. This will be all based on data and research. Next, we'll talk about limitations in rural data, followed by the changing context of data and research. And then we'll close out by talking about data resources and where you can find data. I do want to sort of disclose here that some of these topics are sensitive at the moment, and I would appreciate it if you considered this presentation on background. I'm happy to talk more about this as well, but especially around sort of federal and state funding, there are a lot of concerns right now among researchers in some of these topics today. So starting with some of the data, for each of these slides, I will present sort of one number on one area of rural health or rural populations, what we know from one sort of viewpoint, and then we'll talk about sort of how these are used in the media as well. So to start out, we'll talk about rural populations and communities. And when we look at the state level rurality ranges from about 6% in California to about 66% in Vermont. This is from the Census Bureau's definition from the most recent census. So state level rurality varies quite a bit across the country. And then when we sort of drill down in more nuanced ways, there are rural areas across the country no matter how you define rurality. On the left-hand side of the screen is the rural-urban continuum codes. On the right-hand side are the rural-urban commuting area codes. These are both different measures of rurality. The RUCs, or the ones on the left, are at the county level. On the right are at the census tract level. The RUCs on the left, metropolitan areas are purple, and then the non-metropolitan areas, or sort of what we refer to as rural, are in green. For the RUCAs on the right, the metropolitan areas are in black and gray, the micropolitan are in purple, small towns are in green, and true rural are in yellow. So when we look at who the populations are within rural communities, we can see that the population sizes are also changing. In this figure here, which comes out of recent data at the county level, we are looking at the domestic migration rate, so who is coming into and out of different counties across the country. This is only domestically for people moving within the United States. In this figure, the gold show net decreases in population size, and in the purple are net increases in population size. Historically, we've really thought about most rural communities shrinking, but this sort of changes that landscape and that narrative a little bit, that we have lots of rural communities that are actually growing in size as well. A lot of this has happened since the pandemic, and we've seen a lot of people move to more rural areas, especially some of the more sort of vacation type areas. And when we look at demographic characteristics, this first one is going to look at different race and ethnicity groups. We often think about our rural populations as being predominantly white, which on average is true. But there are differences in sort of what the largest population group is across the U.S. In this figure here, we're looking at the largest non-white racial or ethnic group for each county, each rural county across the U.S. These are the darkest shades of each color are the majority of the population is that other population group that is non-white. So within this, I know that's a little bit probably hard to see. Green represents Black or African American, yellow represents Latino, blue represents Native and Indigenous, and red is Asian. Those darkest shades, again, the majority of the populations are that race or ethnicity group. So we see that this also varies across the country. And it's also changing. This figure shows the change in the portion of the population at the county level that are non-white. The blue are showing decreases in that population, and the yellows and golds are showing increases. Most of the rural counties across the U.S. are that darkest shade of gold, which is an increase of at least 3 percentage points in the portion of the population that is a non-white race or ethnicity. And then lastly, for demographic characteristics, we know that there are differences in age groups and sort of the age breakdown of our rural communities compared to our urban communities. In this figure, the darkest green are the non-metropolitan areas, and in the lighter green are the metropolitan areas. And then we're seeing this broken down by age group across the x-axis and the portion of the population across the y-axis here. What's pulled out in that box in the middle are the prime working age adults. And from this figure, we can see that there's a larger portion of the populations in metropolitan areas that are that prime working age compared to non-metropolitan areas. And we see the inverse for older adults, where there's a greater portion of the populations of non-metropolitan areas that are older. Interestingly, most of the younger sort of pediatric and children populations are relatively similar between metropolitan and non-metropolitan areas. Next, we'll shift into rural health status. These are a variety of different measures on what we know about sort of health status and health outcomes among rural populations. I know today we will spend a lot of time talking about Medicaid, and there will be several presentations later about the proposed Medicaid cuts and what those mean for rural communities, rural hospitals, et cetera. This is looking at chronic condition rates in Medicaid-enrolled adults. About 40% of Medicaid-enrolled adults have at least one diagnosed chronic condition. This is officially diagnosed. This is not other chronic conditions that are not diagnosed as well, so it's probably an underestimate. When we look at mortality rates, we see a lot of differences between rural and urban areas in leading causes of death and sort of how prevalent these are. These are the preventable premature mortality rates of the 5 leading causes of death in both non-metropolitan and metropolitan counties. The darkest shades in the solid line, and then the one generally below it, are the non-core and micropolitan areas. We see that they have the highest rates of mortality for these preventable causes of death over time. And in addition to them having the highest rates, we do see different patterns between rural and urban areas here. In the top left are unintentional injury. Next on the top right is chronic lower respiratory disease, then heart disease, stroke, and cancer. In some of these, we see that they are coming together, the rural and urban sort of measures, and in others, they are diverging. Continuing on sort of causes of death and mortality, there was a recent study that looked at rural and urban differences in suicide mortality across the U.S. These are done at the state level, and in most states we see that rates of suicide are greater among rural populations compared to urban populations. Starting here and for several of the additional slides, I have an example of a recent article, a recent sort of public media article around these topics, sort of highlighting how prevalent they are and that these are things that are being talked about and discussed quite actively. Continuing on sort of mental health and behavioral health, we see that there are differences in rates of substance use by mortality, or by rurality and by substance. The ones that are in the blue bars here are ones where non-metropolitan or more rural areas tend to have higher rates of those utilization or substance use, and that's cigarette smoking, illicit drug use, and methamphetamines. Several of these other ones are relatively similar or have different patterns. And then here we have drug overdose mortality. On the left-hand side are the changes over time between rural in green and urban in blue, starting in the 90s up through 2019. Interestingly, around 2015, 2016, we saw the pattern flip, where urban now had higher rates of drug overdose deaths compared to rural areas. On the right-hand side, these are the opioid-involved drug overdose deaths, and we see that the most common are the urban synthetic opioids and then the rural synthetic opioids as sort of the leading groups here. And then the patterns also differ by gender. This looks at overdose deaths among all substances by men and women. In urban areas, or among men, urban areas have higher mortality rates from drug overdose compared to in rural areas, but the patterns flipped for women, where we see that there are higher overdose death rates among women in rural areas compared to urban areas. And that brings us to some more recent national data on drug overdose deaths across the US and some data from the CDC. This example is an example of sort of a positive change and also a cautionary tale about provisional data. This came out in February 25th, I guess, 2025, and the CDC reported nearly a 24% decline in drug overdose deaths across the country. And this is the figure that is pulled from. This figure starts in January 2015 and goes up through December 2024. We've seen that the drug overdose deaths sort of increased steadily when COVID began in 2020. That's where we see this here, that uptick start. And then we've recently seen this big decline, which is really what the CDC was referring to and has drawn a lot of attention here. This is obviously a wonderful thing, and we're all very glad that overdose deaths have decreased, but there are a few things that I want to point out here as well. First is that these rates are about the same as they were pre-pandemic. So I want to caution you that while this is a good decrease and a good thing, we really are sort of just back to baseline. This is still very much an issue and something that we really need to be working towards. This is not something that has totally gone away and is done and we've taken care of. This could be for a variety of reasons. This could be because of the changing landscape around treatment. We could be doing things that are effective in reducing overdose mortality or in reducing substance use. It also could be that some of the factors that increased substance use during the pandemic have really gone away or been alleviated. We have less isolation, people are generally back to work, people are interacting more with friends and colleagues, and a lot of that has sort of gone away as we've sort of returned to a more normal after that. So then shortly after, there was a new set of data that was released in June of this year, and we see this tiny little uptick happen here. This caused a lot of news and a lot of sort of stir around that decrease that we had seen had started to reverse. This was picked up in a lot of different places, and there was a lot of concern about why this was happening, but also a lot of caution that this could just be a blip. But then, just earlier this month, we saw that data be updated, and that uptick has gone away since then. And part of that is because these are provisional data. The CDC has very clearly labeled on their website that these data are provisional for a period of time after they are reported while they are investigated and finalized. And this is something that is true for a lot of different data sources. So when using data that are provisional, I just really caution you to make sure that there are caveats and sort of what that means, and that those stories may change over time. Shifting into vaccination rates, this comes from a study that used a survey on social media to look at people's hesitancy around vaccination for the COVID-19 vaccine, as well as their rates of trust for different populations. This first figure here is showing the vaccination rates over time for the COVID-19 vaccine. The rural areas are sort of the middle gray, the urban areas are the darker gray, and we see that among this survey, which is again done on social media and probably a relatively narrow set of people, but we do see that rural COVID-19 vaccination rates were significantly less than in urban areas across most of the time period where most people were getting vaccinated for the first time. In addition, in this study, they looked at sort of trusted sources of information for people that were hesitant to be vaccinated or were unvaccinated. Within this figure, on the y-axis are the portion of people in that group that trusted a variety of different sources. This top one here with the most trust is doctors, which is wonderful and great. This next clump includes CDC, scientists, and also friends, as being all somewhat similar. Between 20 and 30% of the folks trusted those sources. And then at the bottom here are politicians, journalists, religion, and government. So we see differences in sort of where people are getting their information and also who they trust when getting information. And then shifting into non-COVID related vaccination, this is vaccination patterns among kids under 24 months, looking at if they had their combined 7 series vaccination set. And the bottom lightest gray and then the next one up are being up to date or on time on all of those vaccinations, and then the next one is up to date but with delays. And then we have urban over here, large rural, and small town or rural areas on the far right. And what we see here is that rural areas tend to have lower vaccination rates for children on all of these, sort of meeting this whole series. Our next section is on rural healthcare access. Just like the other sections, these are some sort of picked out measures of access. There are many other ways that we can measure access, but these are ones that are really prevalent and really commonly talked about at the moment. Again, we'll talk about Medicaid a lot more later today, I'm sure. There are lots of concerns over what the cuts to Medicaid mean for rural communities. And the reason why is because Medicaid is such a huge payer for rural communities and also such an important payer for hospitals as well. This figure shows the portion of adults under age 65 that are enrolled in Medicaid by rural and urban status. Rural is the top yellow line and urban is the bottom blue line, starting in 2010 through 2023. Consistently, rural areas have had higher Medicaid enrollment compared to urban areas, and this continues to grow and sort of separate across these populations over time. One of the measures of access that I'm sure you all have heard a lot about and we're seeing both professionally and then I think we are all seeing sort of personally in our day-to-day lives are the closures of OB and labor and delivery units within hospitals across the country. This figure shows the portion of hospitals without obstetrics care over time from 2010 through 2022 from a recent JAMA article. Rural hospitals are this circle marker and urban are the triangle, with total national hospitals being the square here. Starting in 2010, we saw that about 35% of all hospitals did not offer obstetrics care. That has since risen to 42%, and the divide between rural and urban hospitals continues, where over half of rural hospitals at 52.4% have no obstetrics care compared to about a third of urban hospitals. In addition to just the pure percent of hospitals here, I think it's also important to consider how close you are to another hospital. In urban areas, one hospital may not offer obstetrics care, but likely there are other hospitals within a very close radius that do. In many rural communities, this is not the case. Continuing with hospitals, we also see that rural hospitals have been closing over time, and the closures are outpacing openings for rural hospitals. There's a wonderful tracker from folks at the University of North Carolina at the Shep Center that tracks all rural hospital closures. This is something that there are lots of efforts to try to understand why this is happening, how we can prevent this, and how we can ensure that there are rural hospitals and rural care within our communities. And in many cases, we have started to see the shift towards rural emergency hospitals. And then lastly, for access to care are healthcare providers. This is looking at the providers per 10,000 populations in non-metropolitan areas compared to metropolitan areas for 2021-2022. And it covers dentists, primary care doctors, nurse practitioners, and doctors, primary care doctors, nurse practitioners, and dentists. And among all of these different types of healthcare providers, there are significantly greater portions of providers for metropolitan communities than non-metropolitan communities. There is tons of work happening around here on sort of why this is the case and how we can better recruit and retain providers in rural communities, but this continues to be a struggle, and we continue to see a lot of workforce challenges in this space. And then our next section is on factors that influence health. These are really things that are non-healthcare related, but that influence our access to healthcare or our actual health status. Oftentimes we think about these as social factors, social determinants, or social drivers of health, health-related social needs, all of these types of terms that refer to sort of that collection of concepts. And this is just, again, a few of them. Whenever we talk about differences in health or healthcare or health status, one of the primary drivers is always poverty. This figure is showing the poverty rates by age group. Non-metropolitan are in the brown and metropolitan are in the green here. And among all age groups, we see that poverty rates are higher in non-metropolitan or rural areas, and over 20% of kids under 12 are living in poverty in rural areas. With children, one of the topics that we've also seen a lot of discussion around are child care providers. This is something, again, that has been a really big national concern, especially since the pandemic. These are showing the rates of child care establishments per 1,000 children under age 5. The green are showing the 2013 through 2017 numbers. The brown are the 2018 through 2022 numbers. And here we have the non-metropolitan, and here we have the metropolitan. And this looks like there's a big difference here, but when you look at the actual numbers, we're looking at 3.8 versus 3.9 child care providers per 1,000 in non-metropolitan and metropolitan areas, which may not be that practically meaningful. So I also want to caution you about sort of looking at the scale that things are on. In this case, we're looking at 3.3 to 4 as the scale rather than looking at 0 and up, which makes this change look a lot bigger, or makes this difference look a lot bigger. With the digital divide, something that I think all of us have probably encountered and is being discussed a lot around sort of access to telehealth and access to information and economic opportunities. This figure is showing the differences in access to different devices and different ways to access broadband or internet in household broadband, smartphones, tablets, and having a desktop or a laptop computer. The dark blue are the rural areas, the light blue are suburban, and the gray are the urban areas. And we've seen that all of these have increased over time, but there still remains a gap between our rural and our urban communities. However, this data only goes through 2021, and there has been a lot of effort to really increase broadband access since then. Housing is also something that we see a lot of differences in what housing looks like, what the quality is, and how affordable it is across the rural-urban continuum. This is a study that came out of folks at the University of Minnesota looking at differences in housing quality and adequacy between rural and urban areas using data from 2019. However, this is a recent brief that came out within the last year or so. By most measures, they found that rural areas have greater rates of quality issues, housing quality issues, and that includes things like heating problems, utility interruptions, roof or window issues. The caveat is around things especially related to plumbing and electricity. Urban areas tend to have greater quality issues in those areas. And then lastly are extreme weather events. This figure on the left is a recent dashboard that's been developed by folks at Texas A&M with others, and it captures a lot of sort of climate-related data and needs. This is showing the national vulnerability percentile, where the red is the greater vulnerability to extreme weather events. And for this, they included temperature events, both hot and cold, droughts, wildfires, floods, storms, and precipitations. This is not only sort of an issue that varies significantly across the country, and we see sort of different types of weather events across the country. I am living on the coast of Virginia, and we are sort of bracing for the tropical storm that is sort of off the coast. And this is something that probably some of you are also interacting with on your flights home, as well as things like wildfires in other parts of the country, extreme heat events in others, and extreme cold events. While these are increasingly common, they also are something that rural communities are often particularly vulnerable to, with sort of less preparation in many areas and less resilience to be able to prepare, to combat, and to sort of rebuild after these types of events. There's a lot of work happening in the Appalachian region, in Kentucky, and in Western North Carolina to understand sort of the impacts of Helene and other flooding that have happened and how we can learn from and rebuild from those types of experiences in hopes that those can also be used by other communities that may face these types of events. So everything that I've talked about so far, in almost all of them, we have seen that rural areas sort of lag behind urban areas on most of these measures. This goes back to that mantra from the beginning of older, poorer, and sicker. However, that overlooks a lot of the really important strengths and assets that we see in rural communities and really the important value of rural communities to our country. So there's a growing body of work that's really trying to focus in on the strengths and to leverage those assets in rural communities to try to understand or to try to improve health and well-being. This is work out of folks from NORC, And the quote up here is one that I particularly like, and they frame this as building on the assets that are already found in the community and mobilizing individuals, associations, and institutions to come together to build on assets and not concentrate on needs. So sort of a shift in how we think about supporting our rural communities. In addition, rural communities have an enormous role in all of these factors that are up on the screen here, and in most cases, rural are sort of the predominant drivers of these types of factors within the country, and really sort of drawing on how important rural communities are to urban communities and to the country as a whole. Without rural communities, we would really be lacking in a lot of these different areas, especially around food and agriculture, energy, water, transportation, defense, and recreation. So just to highlight a few other strengths, first is differences in social isolation and relationships by rurality. This is showing that rural residents tended to have more social relationships and less isolation by many measures compared to urban folks. This is a definite strength of our rural communities. We know that social isolation can have negative impacts on our health and well-being, both physical and mental. So having these strong relationships is really something that we can garner and harness. Another example are on crime rates. This is showing the differences in violent crime rates in metropolitan cities outside of metropolitan areas and non-metropolitan counties. And across all of these measures of violent crimes, we see that non-metropolitan areas tend to have lower rates of these violent crimes. And then lastly, for one more example of something that is a little bit nuanced, is this measure around housing. This is looking at differences in the portion of folks experiencing a housing cost burden, which is defined by spending at least 30% of your income on housing. On a plus side, we see that rural folks tend to have a lower housing burden, or a lower portion of people in rural areas have a housing burden compared to urban areas, but I think there are also importances here that we need to consider in terms of sort of what those base salaries are, what 30% of that means, and also knowing that there are shortages in high quality housing across the country, including in rural areas. This is also something that we've seen a lot of sort of political action and political will around sort of how we can improve housing quality and costs. So all of those represent some examples of what we know about our rural communities and rural health across the United States. But I also want to talk about some limitations to rural data. And these are limitations that have existed. These are not new, but these are just things to consider whenever you are looking at rural data or research on rural communities. The first sort of bucket of limitations are around sample sizes, data quality, and reliability. First are small sample sizes and invisible populations. In rural communities, we have smaller amounts of people overall, and therefore sometimes we have really small sample sizes that are hard to work with. In addition, we have this problem of invisible populations, or populations that are part of the community but don't always show up in the data. This may be because of response rates and willingness to participate in different data collection methods, and also because of censoring and trying to protect privacy and confidentiality. I do want to note that just because people are not showing up in the data does not mean that they do not exist, and we have to consider sort of what those populations actually look like, even if we don't have data and an understanding of sort of what that looks like. The small sample sizes can be driven by a variety of different purposes or different reasons, including lower response rates and data suppression or censoring. And together, that can mean that we have less reliability and stability within the data, both in a cross-section and over time. We can see small fluctuations can really exacerbate what changes look like over time within rural communities and places with lower amounts of data. In terms of suppression and censoring, the example here is from CDC Wonder, which is sort of the place that you can access mortality data through the CDC. They suppress data that is less than a count of 9 for a county for confidentiality and privacy reasons, and they consider anything that is less than a count of 20 as unreliable because of the large standard errors there and sort of that stability issue. Other issues related to reliability are modeling of data. In many cases, our data that we have on rural communities, especially at the local level, are modeled using a variety of different techniques. Because we don't have really robust data collection in many rural areas across the country, and it's quite expensive. However, modeling data is only as strong as the model that you are using to feed it, just like sort of other things that we talk about a lot. But those data are less likely to be able to pick up on really local level changes and impacts of different changes. Provisional data we've already talked about as a potential, just something to consider when you are looking at data. And then there are also differences in data access by state. Certain states make different data available, and sort of differences in how readily available that data might be and how it's reported. The next bucket of limitations are around geography. And first, we have small versus large geographic areas. When we think about counties as an area and sort of a level of data collection, which is where most of our health-related data is at the county level, these are really large geographic areas in both rural and urban communities. If you think about some of our rural communities that are out west, we have really, really large counties. But then you also think of highly urban areas. If you think of any sort of downtown metropolitan area, a county can really capture a really big variation and heterogeneity in who the populations are within that community. However, when you get down to a smaller geographic level, like a census tract or a block group or a zip code, those also have sort of exacerbated problems around sample sizes and data quality issues for rural communities, but also remove some of that heterogeneity. The next limitation is around granular data. In many cases, a lot of studies that we all work on and studies that you all see use health system data and electronic medical record data or claims data. These are all incredible data sources that are really robust, but oftentimes they are limited to sort of proprietary data sources and limited geographic areas. And in many cases, rural areas are really sort of not the core of what those data sources reflect. And we often have more limited data on those folks. With those types of data as well, we are seeing people that show up to the hospital or have insurance claims, which leaves out people that are not arriving to the doctor. And then lastly, there are lots of data that either don't have rural indicators or have a measure of rurality, but you aren't able to link them to other sources because there's no geographic identifier. These are all done for confidentiality reasons and to make sure that the data is robust to privacy concerns, but also makes it harder to understand what else is going on in rural communities and loses the ability to look at what it might look like nationally and how it might vary. One example of the large versus small geographic sizes is displayed here with the Social Vulnerability Index from CDC. This is a composite measure that takes a bunch of different indicators of sort of risk around emergency preparedness and planning and lumps them all up together into one measure of vulnerability. On the left is the county level version of this measure, and on the right is the census tract version of this measure. The lowest levels of vulnerability are in yellow, the highest are in the darkest blue. And we see that there are some very different patterns here when you look at the county level version versus the census tract version, especially when you're looking at sort of the northeast corner of Georgia. One example I want to pull out here is the very northeast corner of Georgia. At the county level, we are seeing that there is low vulnerability, but then when you look at the census tract version, we see that there are census tracts within that county that range from sort of the lowest to the highest levels of vulnerability. So when using the county level measure, you are missing all of that heterogeneity and variation that exists within the county. The next bucket of limitations is administrative challenges, expenses to purchase data. Lots of data is proprietary or does come with a cost, and there are also challenges in accessing the data because of requirements for certain data systems or experiences or restricted access, which can be lengthy to acquire. And the last one is around sort of what these measures actually mean. I alluded to this a little bit when we talked about the housing price burden between rural and urban areas, but I really want to sort of discuss this for another minute because we know that sort of all of our communities, both rural and urban, differ across the country. We have different physical, cultural, and political landscapes, and those can result in some of these measures being sort of more or less sensitive to changes and differences in those communities and really reflecting more of what that underlying construct is. So some examples are having a personal vehicle. In most rural areas, you need a personal vehicle to really have transportation. It is a pretty good measure of transportation. It still has limitations, but it is one of the best ones we have. In a highly urban area, having a personal vehicle is not nearly as important, and not having one does not necessarily reflect low transportation issues. Another example is the social vulnerability index that we saw a few slides ago. There are differences in how that performs in rural and urban areas across the country, and it's not always in the way that we expect it to be. And then lastly, when we think about sort of geographic access, distance in miles can mean different things in different parts of the country. This can go in both directions in both rural and urban areas. So instead of distance in miles, we're trying to sort of lean towards more drive time, where you're really capturing what that might mean. So all of that is sort of existing access to data and existing data limitations. This next section is going to talk about the changing access to data. And I have rural in brackets here because most of this is about data generally and not about rural data specifically. And that really starts with the executive orders from January of this year. Specifically, we are looking at the gender ideology, and the DEI executive orders are sort of the main ones that have been driving some of these differences in data access. So here's a timeline of all of the things that have happened around this data and differences in access to data at the federal level. I'm sure many of you have been following this quite closely, and some of you have probably also been reporting on it. Those executive orders came out January 20th of this year. About a week later, OPM issued a memo to federal heads and acting heads initiating guidance regarding President Trump's executive order defending women. This is really when all agencies were notified that they needed to make sure that all of their public-facing materials were aligning with the executive orders, which then precipitated this large amount of changes in terms of data being removed and websites being removed. Within that memo, there was the deadline of January 31st, when all data and websites that did not align with the executive orders had to be removed. This is also the day when AHCJ submitted a letter as well with concerns around this removal of data. A day later, advisors from the CDC sent a letter to the CDC asking for an explanation on why the data was removed and when it would be restored. We started to see websites updated with the notice of changes on February 2nd, that the CDC's website is being modified in order to comply with the executive orders. And then a few days later, on February 4th, was the Doctors for America lawsuit was filed. Within this lawsuit, they basically talked about sort of why this data is important, and specifically out of that lawsuit is a quote that the removal of web pages and data sets creates dangerous gap in scientific data available to monitor and respond to disease outbreaks, deprives physicians of resources that guide clinical practice, and takes away key resources for communicating and engaging with patients. We did see some data start to be restored on February 6th. And then February 11th is when the judge ordered data to be restored, or that's when that went through, and it was to be restored by February 13th. While this order has gone through, the data is often sort of changed or does not have as much information as it used to have as well. So what this actually means, on the left-hand side is reporting out of the New York Times. There were an estimated 8,000 web pages across different federal agencies that were removed. The list there shows all of the ones in order from most to least, with the CDC, Census Bureau, Office of Justice Programs, Head Start, Department of Justice, and SAMHSA being sort of the ones that had the most web pages removed. On the right-hand side is looking at data specifically and CDC data. This shows the timeline of how many data sets were available from January through August, and we see a decrease from about 1,300 or 1,400 data sets, a giant drop when that executive order and those changes went into effect at the end of January, beginning of February, and then we've started to see that number increase over time, still not back to its starting level, but again, all of these data sets do not look the same, do not have all of the same information that they did have previously, even if the data set is published again. So on the left of this slide is sort of what happened at the beginning. We saw this notification that the page you are looking for was not found. On the right-hand side is what a lot of the data web pages looked like after that. And this YRBSS data screenshot is actually from earlier, I guess last week, and what it still says now. This is really hard to read on this screen, but it does describe that the data has been taken down in alignment with the executive order and describes that it is because of gender ideology and the Trump administration recognizing only biological sex. The Youth Risk Behavior Surveillance System, or YRBSS, is a survey data collection that has been done sort of across the country for many years to try to understand health behaviors and other related factors among kids. This is a huge data source and one of the only ones we have that covers a lot of these different topics across the country, and currently we cannot access that data. So some other examples of what data was removed are on the left. We have the YRBSS, which I just talked about. There's also the Behavioral Risk Factor Surveillance System, which is sort of the adult version of this. It is also one of the best data sources we have for a lot of health behaviors for adults. The Social Vulnerability Index from CDC, which we talked about a little bit. Atlas Plus, which is a tool with STI surveillance data. PEPFAR, data dashboards, web pages on any of these related topics. All of those are sort of CDC data sources that were removed. Some of these are now back up, but not all. But I also wanted to highlight the Area Health Resources files. This data combines a bunch of different data sources from around the country and from different agencies, and has a lot of data on how we access healthcare. It has a lot of provider data, it has a lot of utilization data. It is a really robust and rich data source that is used quite a bit and was also removed. Again, this sort of phenomena and what this means for all different types of folks has been covered pretty broadly by a variety of different outlets, including AHCJ and KFF, which I know there are people in the room from both of those. So we appreciate that a lot, and they have been tracking really closely what has happened and what this means. And then this is not related to the federal data removal, but I do want to also highlight and sort of changes in data access. The County Health Rankings and Roadmaps is a data source that's used by a lot of local agencies and health systems, especially around community health needs assessments and such. This is set to end at the end of 2026, so just a notice of an important data source that is planning to go away. So what does this mean for the long term? And there are a few things here. First, some data might be harder to find or just non-existent. There are things that we are not collecting right now that we have collected historically. There might be holes in the data and an inability to compare future or previous data because of these gaps or changes in what exists. This also might have implications for understanding the impact of new policy changes. With these holes, we are often lacking robust baseline data to see what the impacts of those changes might be. And then lastly, some studies and research may not control for known confounders, things like race and ethnicity, gender identity, and other factors that we might not have data on any longer, but we know are important for different measures and different outcomes. So in sum, there are existing challenges with rural data. We know this and have known this for a very long time. We know that data is nuanced, but there are challenges with data access and reliability, and that guidance and those changes are sort of happening really quickly. And this means that agencies, researchers, and organizations may have limitations on what they can release, even if it is not federally funded. This is probably perhaps most potentially problematic if with federally funded work where you may not be able to control for certain things or may not be able to release certain things. But I also want to note that different organizations and individuals are responding differently to these different changes with different levels of risk and sort of safety and protections in place. This may mean that researchers and data stewards are less likely or less willing to talk to you at the moment. So I encourage you to still reach out to people, recognizing that oftentimes researchers are in a tough place in terms of what they can and cannot say and can and cannot release. People may be willing to talk to you off the record and give you a little bit of insight into some of the limitations and some of the sort of rationale for what they did and how they did it. And then lastly, there are also some journals that are federally supported, so just keep that in mind as well. So that moves us into using rural data and reporting on research. And I have sort of a set of questions for you to think about if you are reporting on data or research, to think about what you are looking at and also what you are not looking at or what might not be presented. So the first two are, do the study or does the study present analyses by these different demographic characteristics? And then does it also control for those types of factors if you're looking at something with a more robust analysis in it? I encourage you to look at how recent the data is. Are the data preliminary or provisional, modeled or predicted? Was the research funded, and if so, by who? And all of those questions, I think, can help sort of lead to this last question of what research questions or analyses were done and what ones were not done. Are there any natural holes in sort of what you're seeing? And think about where those might have come from. So our last section today is on finding rural data. We talked a lot about all of the data sets that have been taken down or changed, but there are still many data sets that still exist in many places to get good data. A lot of these do pull from other data sources, so when underlying data sources are removed, they may become less robust as well over time. First are the Rural America at a Glance. These come out of USDA every year. Most of the demographic data from the beginning of this presentation come from these reports. They focus on slightly different things every year, but they're really focusing on populations and sort of economic development in rural communities across the country. They have tons of maps, they have tons of resources. It's a great way to see sort of what's happening at a high level. HRSA also has this high need mapping tool. The website is at the bottom of this as well. This includes several of those indices of sort of vulnerability or resilience across the country, but it also includes a lot of other HRSA data built into this as well in terms of healthcare facilities. This one you can also play with the geographic level to look at counties or census tracts. This example here is showing the social capital index across the country. But it also is quite flexible where you can do a variety of different things with it. In this case, I sort of narrowed in onto counties that our health system covers. You can really look at a narrow geographic area. You can also add your own data into it if you want to see something that you have overlaid with something that they have there. And then here's an example of sort of my geographic area. And we are looking at the community resilience estimates are the shades of blue, and then those little target markers are the rural health clinics within the region as well. Another dashboard example is from the folks at NORC and ETSU. It's the Rural Health Mapping Tool. This has a variety of different measures of healthcare access and health needs, as well as demographic information and rurality, which is not always on these measures and these tools. These are all at the county level. This example is zoomed in around Tennessee, but we have data nationally. This example is showing the heart disease mortality rates across the country. And then you can overlay them with other things. So this, again, has the heart disease mortality rate as the blues on the background, and then it's overlaid with the uninsurance rate. Those are the pink dots that are sort of different sizes depending on how high the uninsurance rates are. And with that, this tool, you can click on any county in the country and you can see all of the data and all the figures for each county. This is just the screenshot looking at one county in Tennessee and with the leading causes of death. For each of these tables, it shows the county level value, the Tennessee state value, and the United States, or swap in whatever state you are looking at. Another similar tool, also by NORC and ETSU, is the Recovery Ecosystem Index. This was a tool that was supported by the Fletcher Group and combines a number of different factors related to the strength and recovery supports in counties around substance use recovery. And it gives every county a score on sort of how strong and robust that recovery ecosystem is. This is what that score looks like in particular, but you can also look at a bunch of different data like the former tool. This one is showing drug overdose deaths as the base layer with the different shades of blue, and then the overlay here is the number of substance use treatment facilities per 10,000 population or per 100,000 population. The slide that I showed earlier with Texas A&M's sort of climate index, that has a ton of data in it as well. This is the landing page for that with the overall climate vulnerability, and that's what this sort of tool on the side is. You can sort of select a bunch of different filters and factors here. This is the overall measure, but they divide it into community baseline, sort of risk and resilience, and then climate impacts into a bunch of different categories. This is what it looks like for the community baseline score across the country, with the darker shades of purple or pink being the higher vulnerability across the country. And that breaks down a variety of other characteristics, including health, social and economic, environmental, and infrastructure type challenges. With this one, like many of the other ones, you can click on any county in the US and you can get all of their data and understand where they rank nationally on all these different measures. This is Washington County in Tennessee, and we can see here sort of how it ranks compared to other counties in Tennessee, and then that it's the 75th percentile of vulnerability in the national ranking, plus all of the specific measures on the side. RHI Hub, which I know we had called out already, many of the slides that you saw today, many of those figures come from RHI Hub as well. They are a wonderful resource for data pulling from other places, and also just sort of really great and rich descriptions of everything rural. They have lots of great resources linked here, but they also have a data explorer tool. This is the screenshot in the website for that as well. And my last one is from HCUP. HCUP is the Healthcare Utilization Project, and it captures a lot of data on hospital discharges and expenses from both emergency department and inpatient care. Within the HCUP net, which the website is down here at the bottom, they have the community inpatient statistics section where you can actually pull out data for most counties in the US, depending on sort of their availability of HCUP data. This example here is showing just inpatient stays at the county level for Georgia. And then the last thing that I want to share are some examples from the Rural Health Research Gateway. This is the website that combines all of the research coming out of the Rural Health Research Center program. Anything that we do has to be posted on here for folks to sort of see and read about, including sort of when projects are selected. Those are listed there. So those are often ongoing, but if there are certain topics you are interested in, there are plenty of people through all of the research centers that have lots of information up here, including other folks that are in the room. And then archive data. There are a lot of different folks that are trying to archive old data that may no longer be available that you can go back to over time. These are just some of them. I'm sure there are plenty of other folks that are also archiving data, so I apologize if you are one of them and they are not listed here. But these sources can be really wonderful. If you are not familiar with the Internet Archive and the Wayback Machine, if you want to see old web pages, what they looked like on a certain date, you can also do that here. That's how I was able to get all of the CDC information on sort of the difference in that overdose mortality rate. You can go back and sort of see on a day-by-day and even sometimes multiple times a day what a website looked like to see any changes that have happened. So that is everything that I have for you all today. My contact information is up here, and I'm happy to answer any questions or chat afterwards. But thank you all so much. I know that's a ton of data to start out your morning, but hopefully gives you sort of something to frame what you all will be talking about for the rest of the day today as well. So thank you, everybody.
This is where you ask questions. There's one over there, too. Any questions for Casey?
Hi, thank you for that super thorough and resource-packed presentation. My name is Karen Landman. I'm a freelancer based in Atlanta. I'm sorry to get a little meta here and ask you something that you seem that is specifically about what we cannot say publicly. But you mentioned at the outset, and a couple of times throughout, that researchers are pretty hesitant to share some of these data publicly. And I think we can all imagine why, but I wonder if you can, off the record, on deep background perhaps, just give us some specific examples of what people are worried about and what actual threats exist. Thanks.
Sure. So I think the biggest threat, and probably the one that we hear the most of, is work that is federally funded and concerns on what that process looks like to release that information. There is certain work that is federally funded that does have to go through a clearance process, but not all of it does. If it has to go through a clearance process, that's oftentimes sort of a non-starter for anything that has any of these topics that we know are a little bit sensitive at the moment. We have seen all of the many, many cuts in research funding across the country, and research funding being pulled around topics that are sensitive. So I think that is the biggest threat, is the threat of funding being removed and pulled. This even when the specific project is not federally funded, if folks have other federal funding, I think there's concern that all of that can get sort of wrapped up together. And then many of us are facing some of these challenges at the state level as well, that state politics are playing a role in what we are able to sort of share. From the researcher perspective, I think we are often not the ones that are collecting and developing and releasing the data, but rather the research side of things and the publications on it. I think many people are trying to be just really cautious at the moment, and many universities and research organizations are also being pretty cautious on sort of who talks to who about what publicly. I know that's not a super thorough or robust answer, but thank you for the question. If anybody else that's a researcher in the room wants to share their perspectives, feel free to jump on in.
I feel so bad because I'm going to make you stay uncomfortable for a minute. But so one of the things we're hearing is that people are using kind of euphemistic language, if you will, or kind of language dodges. Yep. Could you talk a little bit about what you're seeing happen in that regard?
Yeah, so we have seen, especially with the DEI executive order, that a lot of these different reports of what specific terminology sort of should or should not be used. We also have seen things come out that have been like, basically, this is the list, but we also don't want you to sort of try to be sneaky and like use other things to substitute in for these terms. That being said, there are plenty of other alternatives that people are using for many of these factors. In many cases, in research in particular, we'll see people, instead of describing all of the measures that they controlled for, they may have something like other demographic characteristics were controlled for, and it's kind of vague and doesn't really get into the specifics there. This is really tough at the moment, and it is different, again, across the country. Different states and different agencies are sort of saying different things. I think there are people that are trying to be creative in this sense. There are all sorts of different creative things that we have sort of seen proposed or used, including, do you spell things wrong? How do you include a citation that has a word that you can't use? All of those types of things are in there. I don't know that people are doing any of those things widely, but I think people are really cautious at the moment, especially trying to recognize that there's potential for things to be, control F'd or like put through AI to try to find words. And even, especially I think in references is where people are particularly concerned, because we can't change the name of what another study did in the past that we're pulling off of, for example. Yeah.
Okay. Thank you so much. Another easy question. With regard to these quote-unquote invisible communities, especially within rural areas, and recognizing that some of those may feel the need to become more and more invisible, especially when immigration status is at play. I was wondering if you could kind of speak to, are there ways based on existing estimates or modeling to ensure that they are still being taken into account? Thank you.
Yeah, that's a great question. And I think that there are many different populations that often fall into this situation. That is certainly one example, but there are also others that are increasingly concerned for very good reason and very different reasons for different populations. The modeling, I think, is up to the data owners and who is doing the modeling, which is tricky as a person who doesn't own the data. I don't have a lot of control over that. I think from a research perspective, people are often trying to include other control measures that may get at some of those things indirectly to try to understand if a community is likely to have a greater portion of certain folks in certain groups. But I think it's going to be really, really hard to understand those populations. There are certainly people who have been deep in the weeds researching these topics and these different topics for decades, and oftentimes are really trusted sources within those communities, especially locally. I think that is probably the only way we will see a lot of data and a lot of research on those populations specifically, completely de-identified and really showing high-level information. If other researchers have other thoughts on how we have or don't have data, or if there are any other considerations there. I also know that a lot of foundations are starting to fund things that otherwise don't have good funding opportunities, and are trying to sort of pick up some of that slack in where we don't see funding at the moment. I know RWJ just came out with a new funding call or funding announcement to fund things that were unfunded within the last couple of months. So I think there's an opportunity potentially for philanthropic funded work to try to understand those populations better. But I know there's tons of concern, and I think even with funding, I think the data collection is going to be really tricky, and there's going to be a lot of concerns from people in participating.
Hi. So when we were talking about the data that was provisional about overdose deaths, I'm wondering if you have any like best practices for reporting on provisional data, because we see that elsewhere when we're talking about like infectious diseases and stuff like that. Like I see provisional data a lot. So yeah, if you have any tips or thoughts.
Yeah, I think number one, it is just hugely important to be very clear in reporting that those are provisional data and giving a description of what that means and why they are provisional. In most cases, the data owner will say how long they are provisional for, or sort of what the follow-up time is for them to be finalized. I also know that if you wait for the final data, you're going to be way behind everybody that has started with the provisional data. I would just encourage you to have lots of caveats in whatever you are reporting, making very clear what that means, and that there is a potential that those numbers are not exact or precise and they may change.
Hey, I know this is maybe not exactly in your wheelhouse, but do you have any data on news and information sources and how those differ between rural and urban?
I don't. I'm not sure. I would guess that exists, but I don't know. But I'd be happy to do some digging and follow up with you if I can find anything.
Is the loss of a rural hospital correlative to a loss of data in a rural community?
Can you say that one more time? Is it what compared to?
Is the loss of a rural hospital correlative to the loss of data in that community?
Yes. I think they are both hugely impactful for a variety of different reasons. For hospital closures and the loss of a rural hospital, hospitals are often the sort of economic driver in their communities, especially in rural areas. They are the number one employer in many cases, not all cases. So not only are you losing healthcare access, but you're also losing economic development and economic sort of stability within that community. The loss of rural data, I think, will be felt nationally. Those data are so important for so many reasons in terms of research and what we know and how effective policies are, or what the impacts of policies might be, how we treat patients, how we learn about infectious disease, all those sorts of things. So I think the loss of a rural hospital is especially felt highly locally. The loss of data, I think, is going to be a national challenge for a while. Thank you so much. Oh.
Can I ask just one more question? Yes. I'm sorry. I tried to get up quickly. I just wanted to follow up on that because I've covered a lot of rural hospital closures. Exactly, just going back to that. If the hospital closes, I'm thinking there's claims data that's lost, but can you just kind of detail maybe a little bit of what data is lost when a rural hospital closes?
What data is lost?
Yeah, like what?
Oh, sure.
What information are we not gaining at a national level from that, say, hospital
Sure.
in this county in Tennessee closing?
Yeah, when individual hospitals close, I think we are naturally losing all the information on utilization within that community. When people are forced into other hospitals, we might pick up some of that data in other places, but that becomes a lot harder to track and a lot harder to understand what's happening in that local level specifically. We have so much data sort of collectively around at the hospital level across the country, including employment data. We have information on financial status and all of those types of factors as well. Benefits for people that are employees of the hospital and all of those. So I think we lose some of that as well. But I think the most natural one is that we are missing the utilization for that community and sort of the nuanced and granular healthcare needs. we're also losing a lot of information about how providers are practicing in that community. And we know that providers practice similarly to those that they practice with. And when you move a hospital, we see that patterns of practice shift among providers as well. So we also sort of ripple down effect may see providers change practices both for good or neutral reasons or for bad reasons where how they are providing care can also shift when they move to different places. Mm-hmm.
Anyone else going to jump up to the mic? Thanks again, Casey.
Thank you all.